Well, good morning, everyone. I think we're going to go ahead and get started. We expect participants to continue to join our webinar as the morning goes on. I'm going to kick us off this morning. My name is Scott Flanders. I'm a physician at the University of Michigan, the physician director of the Michigan Hospital Medicine Safety Consortium, and also the chair of the steering committee for the Mi-COVID-19 Initiative. We're thrilled to have you all with us today. I think this feels like maybe the first time many of us have been able to bring our heads above water with respect to this particular pandemic, and we felt it was a good opportunity to share some of what we've experienced, some of the lessons, the learnings, and where we're going with some of the collaborative COVID-19 work we've been doing across Michigan. Next slide, Jennifer. So this slide lays out our agenda and on our journey for this morning. So we're going to kick it off with a general overview, where we are with COVID, where we are with respect to the Mi-COVID-19 registry, and then I will share some of the key findings we've had, those that we shared in the spring, as well as those that continue to be generated based on all the work everybody did in generating that registry. Dr. Bob Heisey will then lead us in a review of some of the webinar lessons as we collaborated around clinical care across the state. We'll move into a public policy discussion led by the Michigan Hospital Association in their interview with Dr. Jack Washina. And then we'll move on to a session led by Dr. Rania Esteti, who will be talking about adult and pediatric critical care issues, and then an overview of the Society of Critical Care Medicine Michigan chapter. And then we'll wrap up with some next steps. So we have over 650 people registered for this webinar this morning. We're thrilled to see the interest, the engagement of everyone across the state. Our panelists will have video and audio capability. I think those of you attending will not. We do have a Q&A feature where you can type in questions, and we will do our best, largely during the panel sessions, to try and address any of those questions or concerns on your part as they pop up. We do want to take a moment to thank our sponsors and partners, Blue Cross Blue Shield of Michigan, who supports the value partnerships and the CQI programs, the collaborative quality initiatives here in Michigan, which really were a key contributor to a lot of the information we're going to be sharing with you over the course of our morning session. So I want to first say a thank you to the partners that you see here on this slide. This really was a collaborative initiative. It started first with a recognition of an opportunity. A pandemic that really allowed all groups to say we need to support one another, support our patients, our providers across the state in understanding this disease. We collaborated, leveraging each organization's strengths. Mi-COVID19 created a data registry. Our critical care partners helped disseminate best practices. The Michigan Hospital Association, with advocacy, policy, dissemination expertise, all came together so that we could act in the best interest of our patients. And I hope to be able to show you today some of what that action has led to. So I'm going to kick us off with an overview of the current state of COVID-19 in Michigan, and then begin to summarize some of the lessons that we learned from our COVID-19 registry and much of what we shared over the course of this pandemic, I suspect with many of you who have joined prior webinars that we have hosted. This slide shows the current state of COVID-19 cases per million population here in Michigan. And we are at the far right, which actually feels pretty good for many of us. But this journey has not felt good. Way to the left of this slide, back when this started in late March, early April, I think the magnitude of that peak is diminished because of a lack of testing capability. This pandemic largely impacted certain regions of the state, but that was not true in the fall and winter, where everybody felt the surge of COVID-19 cases. And then, somewhat unique to the state of Michigan, an additional surge over the course of March and April of this year. And obviously, following cases comes hospitalizations. And a lot of our work was focused on the care of the hospitalized patient. We don't show the very first peak, but that second peak really affected absolutely everybody across our state. That initial peak allowed certain select hospitals to learn, share with one another, and then that was disseminated broadly at that second peak. And I can tell you, well, from an emotional perspective, a psychosocial perspective, we did not feel good in April. But I have to tell you, from a clinical care perspective, to me, it felt more controlled, more carefully managed, and we were sharing quite effectively in this most recent surge. And certainly, what follows hospitalizations are deaths, unfortunately. And we had no shortage of death in the state of Michigan related to COVID-19. What I will highlight is that you see diminishing size of these peaks over time. And while this graph is by no means the way we would actually analyze mortality rates over time, we did get better. We saw the initial surge with a very high mortality. We learned, we tried to understand, we disseminated. We did better during the winter surge and even better in our most recent spring surge. And I do think a lot of the work of all of you who have gathered with us today, the work of the registry and others help facilitate that improvement over time. But by no means are we done with this pandemic, as I suspect it's not lost on many of you. This slide highlights what's going on currently in India, where the Delta variant is circulating widely, and the Gamma variant in Brazil. In fact, in the United States, of new isolates that are tested, 6% are identified as the Delta variant. And so while we are hopeful that continued vaccination and safety measures will prevent subsequent surges in this country, we are by no means done or finished with COVID-19 or SARS-CoV-2, and we need to continue to learn from one another and share best practices in the management of this horrible disease. So this, I'm going to shift and talk a little bit about our COVID-19 registry. And this is a timeline that we have shared with many of you previously, and really highlights the speed with which we ramped up our data collection capabilities. And I do attribute a lot of the initial development of this to Dr. Hallie Prescott. She is a critical care physician here. The Michigan Hospital Medicine Safety Consortium was in the process of ramping up a sepsis initiative in March of 2020. And she was quick to realize that our hospitalized COVID-19 patients were behaving like viral sepsis. And if we already had a data collection strategy nearly developed for sepsis, could we pivot, add some information, and help us understand COVID-19 much better than we did? That's exactly what happened. Under the leadership of Elizabeth McLaughlin, our project manager for the Michigan Hospital Medicine Safety Consortium, she quickly rallied project managers and teams from all the other CQIs. And really within weeks, we had nearly 40 hospitals abstracting data across the state, which allowed us to share that data in a very timely manner. So this is a quick summary of the registry. We collected data in a detailed and robust manner from April all the way through the end of January of this year. Over 40 hospitals contributed the work, energy, effort to abstract over 3,500 COVID-19 abstracted patients in our database that allowed us to look at detailed clinical data, hospital data, patient characteristics, treatments, outcomes to help us understand. We were able to bring together a health disparities task force that received funding from the Michigan Public Health Institute to look into some of the inequities and disparities that were playing out with COVID-19. And we disseminated our findings. Webinars, peer-reviewed publications. We'll share some of that with you today, as well as the many streams of work that are ongoing that haven't showed up in the peer-reviewed literature, but we hope to have presented soon. And importantly, we started webinar series. Dr. Jake McSparron, Dr. Rob Heisey, who are on this webinar today, were instrumental in helping to share some of these lessons. Blue Cross Blue Shield of Michigan supported these, the Mi-COVID19 Initiative, the Michigan Hospital Association participated. We brought groups together during the fall and winter surge to share, how do you care for COVID-19 patients? How do you expand capacity? What are the randomized controlled trials showing that we should and should not be doing with respect to the care of these patients? And I think this was incredibly impactful with how we managed that surge, and then again, our most recent surge with respect to COVID. So with that as the backdrop, let me share some of the key findings from our registry and some of the successes I feel we have had. So I'm going to start first with some of our early findings that we generated in spring of 2020, when, as I alluded to, certain hospitals, primarily Southeast Michigan, Detroit, were experiencing this disease for the first time. A lot of what we did early on was observe what we're actually seeing. Who are these patients? How are they presenting? This was one of the very early slides we shared within weeks of the pandemic hitting us in Southeast Michigan. And while many of these findings had been reported either internationally in China out of Wuhan or from the East Coast of our country, which is also experiencing significant surges, we were able to share information about Michigan patients and Michigan hospitals to Michigan providers. And I highlighted a few of the interesting and unique findings here. In red on the left, the disproportionate toll that this disease took on our Black communities, the African-American communities, primarily from Southeast Michigan, was clearly highlighted and played out in the registry data we were collecting. To the right, many of the clinical symptoms were similar symptoms we'd seen elsewhere, but nausea, vomiting, and diarrhea. We had very limited testing capabilities. Our registry showed that nearly 1 in 5 patients presented with those symptoms, helping inform our ER providers and others who might be considered for diagnostic testing when there was a suspicion of this disease. And I think one of the real powers of the Blue Cross Blue Shield CQIs that we leveraged in the Mi-COVID-19 initiative is to look at care across hospitals, look at variability. With the CQI model, very often we are trying to reduce variability because we know what best practices are, and variability is usually not a good thing. However, in this case, variability reflected uncertainty. We didn't know best practices. And it actually allowed us an opportunity to say, what questions are providers struggling with that we need to provide answers to understand how to care for these patients? And this slide highlights the huge variability that we saw with COVID-19 treatment. And I highlight in red right there, concurrent antibiotic use with COVID-19. These patients were presenting with infiltrates on their x-rays, coming in with respiratory compromise. Do you give them antibiotics? Do you not? A large percentage of patients did, but the variability was huge. Some hospitals, 96% of those patients received antibiotics, and other hospitals, only 24%. We needed to help answer that question. Who should and should not get antibiotics when they're hospitalized with COVID-19? And mortality. Another power of the CQIs, we look at longitudinal follow-up, not just hospital care. We call patients. We look at what happens to them after they're discharged from the hospital. Many were reporting on mortality due to hospitalization from COVID-19. We had a unique ability to look at what happened after they were discharged from the hospital. And look in red there. We were able to report early on 1 in 10 patients who survived an ICU stay in the hospital died within 60 days of follow-up. That let us know we needed to target that ICU population surviving a discharge and think hard about what they would need to either stem that mortality or plan for it if a patient was transitioning to comfort care. Important lessons. And by calling patients at 60 days after discharge, we're able to ask questions that clinical registries, electronic health records can't capture. And we were able to describe the huge social, financial impact this disease was having in our patients. And I highlight again here in red, if you were hospitalized with COVID-19, required ICU level care, and survived to discharge into 60 days, fully 1 in 5 of those patients in the early stages of the pandemic had used up all or most of their savings. This was eye-opening for many of us. It spoke to the need to engage our social workers, our care management teams, and others to really think about what these patients needed to support them even after they left the hospital and survived a hospitalization with COVID-19. So those were some of the early findings that we saw. We shared with webinars, literally within weeks of the surge hitting many hospitals across the state. But we did have the opportunity to do deeper dives to answer some of the questions that I raised previously, publish those in the peer-reviewed literature so that others around the country who maybe hadn't experienced COVID the way we had in Michigan could learn. And I would say we disseminated to the international community too. Some countries who had been through COVID and others that would subsequently experience. So we really had a strong interest in dissemination. Let me highlight a few of those findings. So this was one of our initial publications focusing on those 60-day outcomes in patients with COVID-19. This was work led by Dr. Vineet Chopra and Dr. Holly Prescott, who collaborated with additional authors looking at outcomes in the registry. It was published in the Annals of Internal Medicine. And what this publication showed was the significant physical, mental, and financial challenges that our patients were experiencing. This publication hit at a time a debate was raging in our country, largely a political one, over whether we should shut down, whether this disease was important or not, what were the long-term consequences. And I think our publication added significantly to that. This also highlighted to us the importance of social media. It took Dr. Atul Gawande and Dr. Eric Topol to tweet about our findings. And what they tweeted was a key finding. Of those who'd been working at the time they were hospitalized, 40% either lost their job or were too sick to continue work at 60 days. And when those two, who have over a million of followers on Twitter between the two of them, tweeted that out, the news media followed. CNN, International, India, Indonesia, an appearance on the Today Show that we think added significantly to the knowledge base around this disease and was able to let people know this disease has serious consequences. If you contract SARS-CoV-2, you develop COVID-19 and are hospitalized with this condition, it can have devastating consequences. And related to the consequences after hospitalization, we quickly recognized the importance of follow-up. There have been other studies that show timely follow-up with a primary care physician within 14 days after discharge can prevent medication consequences, reconcile meds, prevent readmissions. And yet early in COVID, we documented that that was rarely happening. Only 9% of patients were actually being scheduled a visit with a PCP on discharge. And there were a lot of reasons that went into that. Our hospitals were overwhelmed, for sure. But we learned, we shared the importance, and we got better. In that second wave, 25% of patients had a visit scheduled with their PCP at discharge. Still lots of room for improvement. What I don't show here is the variability. There were some hospitals that never did that. The rate was 0%. There were also some hospitals that did it at 90%. And we do have the ability to look at that impact on outcomes, but huge variability in an important issue. And we went back, given the work that the Michigan Hospital Medicine Safety Consortium was doing with respect to antibiotic use in hospitalized patients. We had several ID doctors across the state that have been working on this, and we used that as an opportunity to engage with that group, understand antibiotic use in patients with COVID-19, who was bacterial infected, who should get antibiotics and who should not. And we had important learnings from that. What we found is highlighted on this visual abstract. 56% of patients who were hospitalized with COVID-19 received empiric antimicrobial therapy, but there was huge variability across our hospitals. Importantly, in the middle part of this slide, we were actually able to look at the rate of bacterial infection in COVID-19 patients, and that was rather rare, only 3.5% of patients. Subsequent studies that I'm not showing you here highlighted that it was the ICU population that developed these infections, and primarily after they'd been hospitalized for a period of time. On the far right, important lessons. A low procalcitonin had an incredibly high negative predictive value for ruling out bacterial infection. And this allowed us to determine populations that did not need antibiotics when they were hospitalized. And what this slide shows is on the left, it focuses on non-ICU patients admitted with COVID-19, and it shows rates of empiric antibiotic use. And as I alluded to in wave one, it was actually quite high with significant variability. As we shared who should not, focusing in particular on this non-ICU patient with a positive SARS-CoV-2 test on admission, we reduced empiric antibiotic use significantly. Less variability with fewer hospitals empirically giving antibiotics to all patients. So significant improvement based on the learnings from the registry. And this paper was just actually published in JAMA Network Open on this past Friday, looking at a very important and controversial topic, and that's anticoagulation use to prevent or treat venous thromboembolism in patients hospitalized with COVID-19. And there were a lot of interesting findings. Our data largely reflect the early surge from March to June of 2020, reflected 1,300 patients in the registry. And interestingly, receipt of any dose of anticoagulation during hospitalization was associated with lower in-hospital mortality. But it was largely receipt of prophylactic anticoagulation when compared to no anticoagulation that preserved an association with 60-day mortality. And to the right, we saw significant changes over time. Missing prophylactic doses decreased dramatically over time. And empirically treating without any imaging to confirm venous thromboembolism increased dramatically over the course of our work with the registry. And this is a graph that I think is very telling as to what was playing out in the early phases of the pandemic. This graph shows hospitalized patients who missed 2 or more days of VTE prophylaxis, and it breaks it out by week of admission. As you can see, skipping prophylactic anticoagulation dose was quite common when these patients first hit our hospitals. We learned fairly rapidly. Publications about the risk of blood clots in this cohort came out. We shared information from the registry. And look at this, from 80% down to nearly 0 patients missing prophylactic doses. I think this rate of change in clinical care is unprecedented, certainly in my time as a physician, and impressive as to how quickly things change and we learn from one another. And this slide shows the rate at which patients received any anticoagulant early on and later. By the end of that first wave, 82% of patients were receiving it. There were a lot of studies coming out looking at the benefit or lack thereof with treatment anticoagulation. Nevertheless, commonly used, 93% of patients received any anticoagulant. And this is a mixture of both treatment and prophylactic anticoagulation. And I think Dr. Heise and his group will discuss this a little bit more in the webinar as we progress as to who should and should not receive systemic anticoagulation. So that was a quick review of what we've published to date and that you have seen or will see in the peer-reviewed literature. We have ongoing work. Some of this we hope will be coming out quite soon, and we continue to look at the registry and look at our learnings with respect to COVID-19. Work being led by Dr. Hallie Prescott is working to develop a simple, easy to use mortality risk assessment model. What you see here is a link to a Mi-COVID risk calculator. Feel free to try this out, but the model is a very simple one. It uses only age, first recorded pulse oximetry, respiratory rate, and creatinine on admission. It combines the overall hospital mortality rate for COVID-19, but the model still has strong predictive ability without knowing your hospital's overall COVID-19 mortality rate. Simple, easy to use, quick mortality risk assessment at the time of admission. As continued work happens here, we hope to be able to disseminate broadly this work over time. Health disparities. I alluded to this earlier. We had a health disparities task force. They received additional extramural funding to do their work with very important learnings. On the left at the top of this, I think somewhat encouraging, I highlighted how disparities, racial inequities played out with respect to who contracted COVID-19. Somewhat reassuringly, if you look at actual hospital outcomes and clinical care in the hospital, our group was not able to find differences based on race or ethnic makeup. However, if you look at the far right of this side, patients living in zip codes that had high social vulnerability were far more likely to have a complicated course, need mechanical ventilation, require ICU stay. But I think a very important finding was actually the horrible job all of our hospitals, mine included, does in capturing race, ethnicity data. If we are going to understand disparities, mitigate social inequities, we need to understand our starting point. And as we dug deep around this issue, we recognized we were very limited in doing so. So I think key clinical takeaways for this is to really engage with our IT teams, develop electronic medical record capabilities that actually allow us to better identify race, ethnicity, social determinants of health. We don't do that well. We need to engage our patients around these if we're going to understand and mitigate these. And mental health. I alluded to the financial, the social toll. We had several have been looking at our registry and have highlighted incredibly high rates of anxiety, PTSD, loneliness that occurs in the 60 days after discharge with a COVID-19 diagnosis and a hospitalization. So in other words, we need to recognize this. We need to screen for anxiety, PTSD, reach out to these patients, engage our social work, our mental health professionals. Telehealth has been instrumental in broadening our reach and able to engage a larger swath of our patients. And many hospitals have actively engaged social workers to try and mitigate this problem that we're seeing in our patients after they survive a COVID hospitalization. And finally, opioid and benzodiazepine use. Many of you may be familiar with the M-Open Collaborative, one of the Blue Cross Blue Shield CQIs, works on reducing unnecessary, inappropriate opioid benzodiazepine use in surgical patients, medical patients, across all the CQIs and across the state. That group looked at our registry and shed a light on opioid and benzodiazepine use in patients with COVID-19. And what they found raises some concerns. 1 in 5 patients with COVID-19 received opioids, 13% received benzodiazepines. And that exposure in a hospital, 4-fold increased risk of having an opioid prescribed at discharge if you received an opioid during the hospitalization, 6-fold if it was a benzodiazepine. And in data I'm not showing you here, nearly 10% of patients who were opioid naive received an opioid at discharge after being hospitalized with COVID-19. And we know from other data that of those patients that receive a discharge prescription for an opioid at 90 days, 40% are still taking opioids. So understanding who does and does not need opioids, benzodiazepines, I think is a critical issue with respect to COVID-19. And I think this requires additional work moving forward. So I think what I have shown you has been a journey that we have taken over the last year plus with all of you. I hope you recognize the immense amount of work that has gone in by a large group of people, including many of you on this webinar, who joined our winter surge webinars, shared experiences, lessons. I think that significantly improved the outcomes for our patients here in the state of Michigan. So I'm going to transition this right now and introduce Dr. Robert Heisey, who many of you know. Dr. Heisey is a professor of medicine, and he is the medical director of our medical ICU here at the University of Michigan and Michigan Medicine. Bob was instrumental in some of the webinars we held over the winter months, and he's going to share some of the top lessons that we learned over that webinar series. So I'm going to turn it to you, Bob.
Great, thank you, Scott. Good morning, everyone. And I have the privilege of representing the Michigan COVID-19 webinar series that went on, as Scott points out, in the fall surge. This was organized by my colleague and pulmonary Jake McSparron, as well as Heidi Moreland and the ever amazing Greta Krapol. And so I don't want to take credit for their work. They organized that. And I'm representing a lot of people today who spoke in these seminars. And you have to acknowledge that I'm giving you my take on lessons learned. I freely acknowledge that other people may have other ones. But let me share with you just 5 slides, really, and tell you what I think has been important over this last 16 months, which seems like 16 years, frankly. Okay, let's see if I'm, there we go, great. So lesson number 1 really is a lot of what we thought at the beginning of the pandemic, we got wrong. And as I said, it's hard to even remember what it was like in February of last year when things were circulating from Wuhan and JAMA. Only 1 patient got off the vent. Many of us in pulmonary critical care had this anonymous email with observations from a provider at, we think, at University of Washington, where Seattle got hit early about these COVID ARDS patients and clinical pearls. I mean, it was. I'm not saying it was hysteria, but everyone was bracing themselves for what was coming next and trying to understand what to do and how this might be different. And so a lot of what we thought early on, we got wrong. So let me place my space bar. I don't know if I'm advancing. There we go. Great. So one of the things that was circulating was that hypoxia really advances rapidly. A patient will come in on a couple liters of oxygen, and gosh, when they hit 6 liters, their fate is cast. Just put them on a vent. There's no point in trying to temporize. They are going to be on the vent. And start my video. I'm sure that means. And so just give it up. Don't bother trying to use other modalities, because after all, we have some things that we use in critical care, such as heated high flow and non-invasive ventilation, and you'll be putting potentially your providers at risk for getting infected. So just when they hit 6 liters, they're done, hook them up. Don't bother trying to do these other things. We were using, remember, hydroxychloroquine and azithromycin, these agents that were not proven, but everyone was using. When I first, we opened the RICU, everyone got it. Our ID guys were on board for that. And I'll tell you, we in the Penal Network did a hydroxychloroquine study, and I was arguing, wrongly as it turns out, that we should randomize 2-to-1 for hydroxychloroquine, because I thought at that point everyone was using it. We'd have a hard time enrolling patients because they want to get the drug. But we enrolled 1-to-1. It was a negative trial. So these things that we thought would be helpful were not helpful. Don't use corticosteroids. I can show you a file. Again, this was circulating early on. Everyone's sharing information. This was from Massachusetts General, kind of a poster of sort of COVID's do's and don'ts. One of the don'ts was don't use corticosteroids. And I think that this was a heuristic based on data we had related to the H1N1 epidemic, where in the first 3 days with active viral replication, mortality was higher in the H1N1 population. So don't use steroids. So early on, things were, everyone wants to do the right thing and adapts from earlier experiences to what we think we needed to do, but these things turned out to be the wrong thing. And so what did we learn? Now, Scott pointed out our mortality and commented, and rightly so, that mortality went down. And you could argue in many ways it's a tale of 2 pandemics. The early phase, March, April of 2020, high mortality. Subsequently, that mortality went down. If you look at the left-hand panel, this is UK data from the Blue Journal, but our data is similar. Early on, you can see many patients were on the ventilator right away, and then by the late spring on into the summer, the percentage of patients who were on invasive mechanical ventilation on tracheal tubes went down. Mortality rates improved too. This is US data to the right. And the line of identity here is the March, April 2020 timeframe. So in other words, we're comparing May and June, July and August, September and October, as you read from top to bottom. And in each instance, the mortality compared to that horrible first surge in March, April 2020 went down. So we did learn along the way. And by the way, of course, as you realize, this was pre-vaccine. So we've had our horrible April 2021 surge with many patients vaccinated, but even before we had vaccines, we were doing better with this population, and we weren't putting as many people on the ventilator. Now, maybe that's because we were temporizing with heated high flow and non-invasive, such as helmet ventilation. Also, there were treatments we were offering that we weren't offering at the beginning of the first surge. Oh, sorry, I have to back up now. Page up, I double click. There we go. Right. So lesson 3 is that we learned that different interventions work at different points in the disease spectrum. The box you see is the ordinal scale, the WHO ordinal scale, which follows patients sort of in disease severity from being uninfected to ambulatory all the way to having severe disease, which is heated high flow invasive ventilation ECMO, and onto an ordinal scale of 8 or death. And we've had remdesivir available across the hospitalized spectrum, as you see to the left, which goes from mild severity and all the way through to ECMO as being a modest treatment effect, but effective. But other things that were studied at different time points in the ordinal scale turned out not to be effective. So let's look, for example, at the neutralizing antibody cocktails that Lilly, Regeneron, and I think GSK also have marketing. Now, by the way, just so you know, that when you talk about monoclonal antibodies in the treatment of COVID, they come in two kinds. Neutralizing monoclonals, which are amplified from patients who recovered. So these are essentially antibodies created by people who recovered, identified, and then created in the lab, versus monoclonal antibodies against inflammatory markers, in particular, JAK inhibitors or IL-6. So they're 2 different kinds of things, but as part of one of our research networks, Active 3, we've studied in the inpatient setting these monoclonal antibody cocktails, one after the next, and they've been negative, yet they seem to work quite early on when you're ambulatory. And we set up, as many of you are familiar in Michigan medicine, out at West Ann Arbor Satellite, an infusion center for these early patients. Now, if you think about it, in hindsight, it kind of makes sense. If you already have a high viral load and your inflammatory markers are shooting up, maybe a neutralizing monoclonal antibody infusion is a drop in the ocean and less likely to be impactful. But we studied it, it didn't work. Along back on the left side, again, corticosteroids. As I mentioned to you early on with H1N1, we didn't think that would be useful, and yet corticosteroids, the signal has been consistent across the board, not just the large British recovery trial, but across the board, there's been a positive signal for corticosteroids. Now, what's true about it is these are patients on oxygen. When you do the subset analysis, if you're hospitalized or have mild disease, corticosteroids are not beneficial. They did not appear to be in the subgroup analyses that have been performed, yet hospitalized patients on oxygen clearly benefit. I put the other kind of monoclonal, the anti-IL-6 medication, tocilizumab, with a question mark, but this is just, as corticosteroids are anti-inflammatory, and again, the notion here is you've got viral replication, you have a lot of inflammatory markers, corticosteroids can smack down that cytokine storm, that overactive immune system in a very broad brush manner. Tocilizumab a little more targeted with interleukin-6 monoclonal against that for inhibition. The data has been a little more equivocal. I know Ranya's going to comment with her panel later on as to maybe why that might be. The REMAP group had a positive signal, others have not. But clearly, the anti-inflammatories don't work in the mild cases. This is for that cytokine storm. Moving over to therapeutic heparin, I was intrigued by the information that Scott shared with you because it does echo some of the things we did. This is active 4 studies that were done in the US as part of the therapeutic arm or Operation Warp Speed. The first, we were studying patients not only with moderate disease, which is to say hospitalized on the floor, but severe disease, which is hospitalized, heated, high flow, non-invasive, invasive ventilation or ECMO. And in December, the therapeutic anticoagulation for the severe disease was stopped for futility. All right, so therapeutic anticoagulation did not work in the sickest of the sick. And I'll tell you, this is why you do the science, because my lack of equipoise, again, bias would have been, this is the exact population, you would assume that therapeutic anticoagulation would work. And we know that the clot burden in patients with ARDS and the microvasculature is significant, leading to dead space and worsening oxygenation. It seemed like that ought to work. And when I was enrolling patients in the moderate arm, I kind of thought, well, if they qualify, just recruit them. But everyone knows this is going to work in the severe arm. But it turns out the severe arm, futility. And then January 22nd, announcement by NHLBI, therapeutic anticoagulation works in the moderately ill patients. And so big surprise there, but that's why you do the science. And I'll tell you, both papers are under review at New England Journal. They should be out within the next little bit, but I know from talking to Jeff Barnes, there was a somewhat contradictory Brazilian study about therapeutic anticoagulation. So the story needs to be worked out, but clearly therapeutic heparin seems to work best, if at all, in the hospitalized moderate patient, not the severe patient. And finally, the JAK inhibitors, which seem to only work in the moderate to severe population. And I put R because almost every study now is done with remdesivir in play. So we have essentially 3 patient profiles here and different interventions at different points in the 3 patient profiles. So the ambulatory patients get the neutralizing monoclonals when their viral load is small, perhaps to buy time for their own immune system to rally against the virus. The hospitalized mild to moderate patients who are on oxygen or not may benefit from anticoagulation. If on oxygen, they benefit from corticosteroids. Everyone's getting remdesivir in the hospital. The severe patients benefiting not from therapeutic anticoagulation, but also getting corticosteroids. So the 3 populations have different interventions. This is now, in hindsight, you could argue this makes perfect sense, but I think at the time we just didn't know. And I will also make a pitch for science. A lot of this, I've never seen science move as quickly in a collaborative fashion as I have in this last year and a half. Everyone knows Operation Warp Speed, and rightly so, from the vaccine effort, which was amazing and got to market quickly. But the therapeutic arm created networks of networks to all do interventions quickly on a large scale, so that we now are smarter, that we now do better. And I think that we've borne, this effort has borne fruit, and it's been a great privilege to be part of that work. So lesson 4, and this is for you ICU docs out there, you may be familiar with this controversy, is that ARDS, we already know it to be a very heterogeneous condition. That's fine. But early on, and still continuing, was a notion that somehow that this entity is different. This is a different kind of ARDS. And the reason this is important is we've had lung protective ventilation for 20 years, and that's been an important thing for me personally to try to support the dissemination of that. And the notion here was, well, you know what, these patients are qualitatively different from regular ARDS patients. They have a higher compliance, i.e. their lungs are not as stiff. They have this notion of happy hypoxia because of the clot burden in the microvasculature. And there were already some concepts circulating, Lucio Gattinoni and John Marini, about mechanical power and the Willi vortex. In other words, one of the notions of intubating these people early, maybe condemning them to invasive mechanical ventilation, which I think in hindsight turned out to be the wrong thing to do, was that wide swings in transpulmonary pressure through vigorous respiratory efforts may worsen the lung injury. So the notion here was, gee, these low tidal volume that we've been advocating for 20 years since the original ARMA trial in the ARDS published in 2000 may be inappropriate for COVID. Let's crank up the tidal volume. Oh, and by the way, there was even a French group that said the histopathology was not even diffuse alveolar damage. It was what they call acute fibrinous organizing pneumonia, AFOP. Well, I'll give you my bias, and I think most people have come around, and that this is ARDS. ARDS is a spectrum. We know that regular ARDS also has a subgroup of highly compliant patients. There's clearly considerable overlap in terms of lung compliance. We know that there are pulmonary microthromboemboli seen, but they were present in H1N1, and dead space being increased, which is to say clot receiving ventilation as a contributing factor towards hypoxemia other than shunt with alveolar filling. We've known about this for a long time. I mean, when you look at the original ARDS data by quartiles of dead space, mortality went up by worsening dead space. And I owe it to my colleague, Jeff Myers, who showed with adequate control groups that the histopathology isn't this AFOP, it is diffuse alveolar damage, just as we thought. So I know that's a little arcane for you non-intensivists in the group, but don't forget too that in conventional good old-fashioned ARDS network lung protective ventilation, you could go up to 8 per kilo provided your plateau pressure stayed below 30. So no one ever said that this notion of a highly compliant subgroup isn't there and shouldn't be treated differently. But I think that the notion we should throw all of our experience away of the last 20 years and treat these patients differently is wrong-headed. The last lesson I want to share with you is that this was hard. And, you know, it's been, for me personally, as horrible as this pandemic has been, it's been a great privilege to be part of the work, the research work, the patient care, and the teamwork we've seen in Michigan, the organizational efforts of Scott and his group, these webinars. But this was hard, particularly for our frontline providers, the people in the room. There are nurses, our respiratory therapists, our housekeepers. This is a letter that my colleague Tom Bailey published. I hope you can see it. Maybe I made it a little too small, but we had really draconian limitations due to the pandemic on our visitors. And this was a questionnaire. He had 49 Michigan hospitals respond. And not only was it hard on our frontline providers to be in the room, to don the PPE, but to also have to serve as surrogate families to hold up the iPhones while they're FaceTiming their loved ones. This was hard. My hope, though, and you know, some people are predicting a fall surge. I really, truly hope that this is behind us now, and maybe we will have an opportunity, like Ferdinand de Boll, to get through our collective pandemic anosmia and smell the flowers for a minute. And for that, I wish to share with you as my final slide something that we're going to do here in Michigan. I stumbled upon the work of a guy named Brian Dories recently, who coincidentally has the same alma mater as me, but that's not why I'm interested. And we're very pleased to have the support of MHA and Blue Cross to put on a seminar on June 30th, 8:30 p.m. And what this is we'll have some live readings of some Greek tragedies, and then we'll have a panel and a discussion. And again, I owe it to the ever amazing Greta Capel and her efforts to help push this forward. And basically, I hope we're able to turn the page. I hope this will help to turn the page. We do need some volunteers to stand up who are in the room that may have experienced some of the moral distress to be part of our panel, or what we're calling our third chorus. So here's the Theater of War website, and there's my email if you're potentially interested in serving on this panel. Give me a shout out, and Greta and Hailey Moore are going to start working this week on establishing our panel. So that's what I have for you. I hope you, thank you for your time. I hope you, with me, feel that these COVID-19 webinars were important in sharing the work and improving our care in Michigan. And so with that, I'm going to turn it over to Laura, and we're going to have a little discussion about public policy and pandemics. So thank you for your time.
Thank you, Dr. Heisey. I appreciate it. And I think that the upcoming webinar looks terrific. So it's my privilege to introduce Dr. Jackie Washina, who is a multi-talented physician. He is a professor of internal medicine in the Division of Pulmonary and Critical Care Medicine at the University of Michigan. He's part of the Survey Research Center at the Institute for Social Research and the Center for Clinical Management Research at the Ann Arbor VA. I think probably many of you already know about his work, but his research focuses on the organization of critical care services to provide high quality and value and improved outcomes. And so I'm really excited to talk about some of the non-clinical and yet very important issues that impacted people who were doing the clinical work. And Doctor, let me start with, in terms of the clinical, or excuse me, in terms of the policies that were out there impacting your work, let's start with what worked well.
Thanks so much, Laura. So guys, we're going to try to do this a little bit as a conversation with hopefully some of the screens flipping back and forth, or maybe there's a way for Laura and I to both be on the screen at the same time. We're not going to lie to you. We definitely had a prep talk in advance, so I kind of know what the questions are. She's not going to throw gotchas at me, I hope. Maybe she is. I don't know. It could be interesting. You know how doctors and MHA get along sometimes. But this is supposed to be a little bit of a more informal, a little break from PowerPoint. So I should also say very clearly, I am a tenured faculty member, which means I get to mouth off without necessarily as many consequences as people who have a day-to-day jobs. And you may want to just keep your eye on Scott's face and just see if you see him typing furiously to my dean. So these are just, if you agree with me, these are the opinions of maybe the organizations, but if you disagree, it's definitely just me talking, and none of this has been vetted by any of my higher ups in advance. So what worked well? When I think back to those early days in March, right, of last year, and so I live in Ann Arbor, and the university got sent home, and the city of Ann Arbor's response to that, if you were in the 18 to 25 group, was clearly this means we should get together in aggregate groups as quickly as possible. And there is, it's a bad idea to tell students on St. Patrick's Day that they don't need to come to class on Monday. And that was rough. And then the state got involved, and we shut this state down. And we shut the state down quickly, and people complied. And if you look at the curves for our hospitalizations and the Bronx's hospitalizations in March of last year, they're overlapping. And the reason that Southeast Michigan didn't go into the annals in the way that New York City did as an epicenter of death and destruction is because we shut our state down before they did. And we did it very effectively across a range of components. and we did it without having to use police or violence, and that it was a collaborative effort, and that worked really well. I think we also cleared hospital beds in that first wave in a way that allowed us not to use excess sites of care, right? We all know that the Cobo Center was kind of having plumbing put in it, and that the Michigan Field Hospital was potentially going to go up, down on our track. And there was no real plan for how we were going to, I mean, there were plans, but there was no great way we were going to be able to staff those, right? We could build beds, but nobody on this call believes a hospital bed without a trained team of providers next to it is the same. And because we were able to reallocate hospital beds, we were able to largely keep people in hospitals. And I think I have a marked preference for providing care in a hospital over a hotel. And so I think that took a huge amount of coordination, a huge amount of leadership, and a huge amount of willingness to take risks. I think a third piece is that we provided us a state policy infrastructure that allowed us to reassign clinicians, particularly nurses and respiratory therapists, outside of their usual scope of practice in a way that let them do so safely and without putting their licenses at risk, right? Last March, we were going in Southeast Michigan to 3-to-1 or 4-to-1 team nursing models in the ICU. That was going to happen because there were too many dying people one way or the other. We, as a state, were able, and in part because of MHA's good work, to do that in a way so that nurses felt like they were protected and respiratory therapists felt like they were protected and could practice well without worry they were going to lose their license and be held accountable afterwards. You know, do we have time for me to tell one short story, Laura?
Absolutely.
You know, so I did a lot of my fall serve over at the VA Ann Arbor, which, as you guys may know, opened up to civilians as part of our 4th mission, and probably 2/3 of our critical ill patients during the surge were actually non-veterans. And so we opened a bunch of ICUs in what used to be, let's call them non-clinical spaces. And I looked around one morning and thought, like, all right, I'm going to do a Pat Posa here. We're going to do a little huddle. We're going to talk a little bit and try to get it. And we went around and everybody talked about what they were. And I was the only inpatient provider who was there. The RTs were introducing themselves in a single word as, I am Joan from sleep. And they were driving vents. And we were able to staff that and provide them the flexibility. And these were folks who hadn't been in a unit in a while. And they provided superb care by adopting a consultative model that was only possible because the state provided the legal flexibility to allow that to be done explicitly, as opposed to the way a lot of us would have had to do it, right? We would have just done it and hit it, and that would have been a mess. And I think the last part, and this may be controversial, is that the rollout of vaccine has gone, all things considered, better than we had any right to hope. While we're not hitting the 90% targets that we all know we need to actually prevent, to get to herd immunity and to prevent another COVID takeoff, I think our vaccine rollout has gone pretty well. So I'd say the early shutdown, the clearing of beds, the professional liability, and frankly, continued vaccine rollout have all been huge wins. And then, of course, I've got to give Blue Cross Blue Shield props because their decision to pivot the CQIs into Mi-COVID19, as opposed to just shut them all down because we're not doing surgery, so we might as well close them, and to both keep those nurses employed, doing good work, and to do all the data that you've seen about, represented a dramatic willingness to innovate that I don't know that we've seen in a lot of other places. So I think there's some real high points.
I want to follow up, just one follow-up that we did discuss earlier, and that is, I feel like for the public and certainly for policymakers, I think they entered into the middle of March thinking we're going to have potentially thousands of people, thousands more people in the state of Michigan who need ventilators, and we don't have them. And, you know, so not just beds, but also vents. And, you know, as Dr. Heisey pointed out, there were a lot of things that we got wrong at the very beginning. And I think the experience in Washington State, you know, they had just a horrific experience. And that was really all that many of us had to learn from, But I do believe that clearing the beds and having the shutdown did give us the opportunity to not have that panic over ventilators. I really feel like that on the outside of the clinical space looking in, it felt like that made a huge difference to that piece. Do I get that right?
I think you're exactly right. Right now, you and I know, but it's important in a multidisciplinary say it, that every time the public said ventilator, what they actually meant was a ventilator staffed by a highly trained ICU nurse. And so they tended to confuse the machine with the highly trained ICU nurse, who's actually essential for the machine not killing someone. But we'll give them a pass, right? Nurses are used to not getting all the credit they deserve. But yeah, I mean, I think if we had tried, and we know this from later components, if we had tried to keep doing all the other things we were doing and hadn't freed up capacity, people would have died because we would have been running out of stuff, particularly in that insane intubate people at 6 liters per minute world that we were in, that I still have nightmares about.
Yeah, I think that this is something that, in terms of things were going well, but the comprehension of, very early on, we were starting to comprehend that equipment was fairly useless without staff. And this will bring us to a great question, which is what didn't go so well? And perhaps the comprehension about just how important staff is and how limited of a resource that is, that might be the top of the list.
Yeah, I agree, right? So when you look at our colleagues in the north of Italy, who I've maintained a brisk correspondence with, in part because I really want to go visit them again as soon as we open up, because God, a few weeks in Lombardy seems really like an important part of my professional development, doesn't it, Laura? But what they did is, as soon as they got out the fall surge, they began cross-training nurses. And they said, there is no reasonable expectation we have that this was a one and done surge, right? They said it's going to come back. And so we need to triple the size of our ICU capable staff. And it's not about the doctors. Scott and Bob, I know, will be the first to agree with me. It's just never about the doctors, right? We are not the scarce limit, the resource limitation. It's about the nurses and the respiratory therapists. And so they trained something like 5,000 nurses in the region of Lombardy to be able to surge up, to provide ICU care and to provide respiratory therapy support, so that when, as everybody could have predicted, the COVID came back, they have been in nothing like the surge struggles that we've been in for the last 2 waves, because they'd cross-train people. We didn't do that, right? And indeed, if you look at our health systems, most of our big health systems came out of the first wave by trying to cut costs and laid off ICU nurses, laid off nurse educators, laid off ID pharmacists, and then and did nothing to expand capacity. And so then you came into the second surge with them going, we can't help anymore. How could we have foreseen this? Because they chose not to prepare as a business decision, right? They scaled back. And we know that or there was some like, well, maybe we'll be able to find travelers. And you're not going to be able to find travelers in a statewide epidemic, right? Everybody who could. And right, that was a choice. Some institutions, right? The VA Ann Arbor doubled its ICU nursing staff in the summer. So that they were fully trained and certified. So when the fall came, they were able to double their ICU beds without needing to do any variances that second time around. And that was remarkable. So I think the fact that we as a state failed to cross-train the essential support staff is a real missed opportunity that we need to understand why we did that, because that was a choice that we made that other regions outside the US didn't. When we talk about what else didn't work, Laura, I think, and this is the one that's going to get me in trouble, I think big hospitals failed to take a responsibility to accept transfers in for COVID respiratory failure from small hospitals, right? If you look at the data our large health systems have let leak out, each of their hospitalization rates for the second and third epidemics are half their COVID-19 hospitalizations are half the size of the COVID work that they did in the first wave. And that was a Michigan specific decision that we made. Sorry, the state of Michigan. I want to be very clear. I am definitely not speaking here on behalf of any health systems with which I may be affiliated. That in other states, the major tertiary care centers set up and maintained large COVID units for the entire year. To the best of my knowledge, none of our major hospitals did, and they all accepted fewer patients in COVID-19 respiratory failure. And that meant they left people to die in small community hospitals. Every one of these hospitals purports to be a statewide center, and for high value care could transport patients anywhere in from the UP very well. They made a decision not to do that for COVID, and that I think is a real failing, right? We didn't close the ORs for the second and third wave the way we did for the first wave. But when you look at that data Scott showed us in the first slide, there were just as many hospitalizations in the state of Michigan as there were in waves 2 and waves 3 as there were in the first one. But there wasn't the same effort from big hospitals to provide the support for small hospitals. And I think,
do you think that this for the states, the policy for the state's response, and there was no time to adjust this. So we had a emergency management system that was responsive to the 9/11 disaster, and it's very regionalized, and also probably designed for something terrible happened that lasted 1 to 3 days,
right,
maybe a week.
Disasters is what we train for.
Right. And very much like, what are we going to do in this region to support each other? So I think it's somewhat difficult to think of things on a statewide basis because of the way that we've regionalized this. Is this an indication of, that we need more of a comprehensive, something outside of regionalization, and perhaps something that thinks of the systemization we've had of our healthcare systems? We're no longer 200 individual hospitals that need to be regionalized. We have organizations that really have a statewide footprint, or at least multiple county footprint. And is that probably something policy-wise we need to be thinking about going forward?
Yeah, absolutely. I mean, I think there are several things to bring up there, Laura, right? Well, one is that none of our big health systems, none of these great health systems thinks of themselves as a single hospital on the hill anymore. They all aspire to be statewide enterprises, and they all have the transport facilities in there, and they all have some degree of coordination. Now, there are places they use that coordination for good, right? Like, you have a devastating brain bleed, we can get you care, right? You have an MI, we know we can get you to a cath lab, we can get you quickly. But you're right, we didn't think about how we do that on a sustained basis. And I think the other thing we found is we had the failure of imagination, and I did it too, right? July 15th, I got in a car and I drove to a good friend's house in Santa Fe. And my wife and I said at Santa Fe, I said, oh, thank the good Lord, that's over. And I did, and I watched what was going on in the South, and I didn't want to plan for the possibility that was going to come back. The biology hadn't changed, right? Nothing about the biology of statewide immunity had changed. But if we're going to look back honestly, and that's one of the great things that the quality improvement tradition here in the state, going back to Keystone, has always said is, right, that you don't have to get everything right. You do not have to get everything right. You do have to honestly admit where you got things wrong, so you can look back and figure out how to do that. And we are one of the few states that has the courage to do that, right? We didn't plan for a second wave. And then when we got through the second wave, everybody got to Christmas, was like, oh, thank God that's over. At least we get a few months off. And then that third wave came and hit us, and we hadn't, right? So in the spring, maybe we could be forgiven for not having seen a worldwide pandemic coming. in the fall, we hadn't built the policy response to think about the coordination. And in the winter we did, right? Fool me once, fool me twice, fool me a third time. I don't think the Proverbs get friendly at that point.
So when we talked last week, we talked about that, we did learn that policy can be effective. The response in the first surge went pretty well, considering how little we knew. We didn't even know what we didn't know. And Dr. Heisey said, that he wanted to applaud the science. And you mentioned to me also that, that it turned out that the science is really what you have to focus on, that really science is where things belong. And then we talked about how, policy-wise, this gets a little bit beyond the state of local public health or the state of Michigan's policy responses or even Blue Cross. And it really goes to more of a federal issue. But we talked about how, we really can do major vaccine studies very quickly. We can break through these barriers to science being administrative. And maybe you comment on that just for a moment.
Yeah, I mean, I guess like Bob, I look back at, last spring at the stuff I was doing, spring 2020, that was using my best professional judgment. And I have dedicated my life to saving the lives of people with sepsis and ARDS, right? I'm not Johnny come lately to this. I did a lot of stuff that was wrong. It was our best guess at the time, but it was wrong. And it was wrong because we hadn't done the science yet, and not merely in the vaccines. Although obviously, as a father of a fully vaccinated, oh, you can't see it because of my screen, of 3 fully vaccinated children, I am a huge fan of vaccine science, but our inpatient science also progressed at an unprecedented rate. And we made major breakthroughs in that. And that's just great, right? And we learned that if there are more ways to be wrong than there are to be right. So sticking to the foundations is real important, but also finding ways to ask questions and then answering them is feasible and can be done. And that people were really excited to be a part of that. People were willing to work extra hours to get their people enrolled in trials and to make sure they brought the benefits of science and data sharing to bear. And we can do it if we have well-motivated professionals and we're working it on the basis of professionalism, that there are some resources, right? So you're not going to do this for no money, because you can't ask people to give up their weekends for no money forever. But also people don't do it for the money. But you've got to find ways to reduce the startup costs of this. That the 6 months to a year that we often spend in regulatory apparatus beforehand is a huge impediment to science, and that it's a choice, right? That we could get that out of the way and get that down to 3 weeks, 4 weeks to stand up the hydroxychloroquine trial nationwide was really important. And it's cool. Sorry, Laura, I feel like I gave you a rambling answer to that question.
No, it fits into, I read Arundhati Roy, who said, pandemics are a portal, and you can go through the portal dragging all of the baggage behind you, or you can go through the portal lightly and with little and try and have some new beginnings. And I think that that's kind of what you're saying here is we've figured out some ways to not bring so much with us in terms of the regulatory aspects of these things. And I think that that's really a learning that we have, and whether or not we can execute on that is going to be tough, but I think it's certainly something we could take with us. We have a question from the audience. Go ahead.
Just before the video, I mean, it's also probably embarrassing and speaks to the sort of the world you and I live in, that we're 21 minutes into a conversation about the policy response to the single most racialized epidemic that, God willing, either of us will experience in our life. And we haven't mentioned just how many Black people died in the state in the first wave. And that we had, with Lieutenant Governor Gilchrist's commission on this, we had a franker conversation about racial disparities in COVID-19 in the state than we've ever had before. We ain't fixed them, right? We have not fixed them. But the data has been strongly suggestive that conditional on your health system getting people into the hospital, which is access is crucial here. It really looks like we're providing equitable care to people with COVID-19 across a range of components about this. And that a lot of the initial disparities, which were so appalling, right? I mean, the excess death was so much among our Black and brown Michiganders in this country, in this state. The excess death really has much more to do with, are folks getting into the hospital at the same time? And then once they're in the hospital, are there, some components of that transfer component of that, right? So that there are big disparities among hospitals. So if you go, not all hospitals were interchangeable, but once one got into the hospital, the within hospital disparities were modest to nil after, at least once we got the data up and going. And that's really important. Although it does suggest, given that we know Black and brown Michiganders tend to live in areas where they go to hospitals that are often less well-resourced and have worse outcomes, that again, the transfer system has a racialized component of this as well as the rural Michigan parts of this that are really hard. Sorry, Laura. I cut you off.
No, that's all right. We had a question from the audience about, is there an explanation of how the surge was in one area of the state in the beginning? Southeast Michigan took the hit, and exactly people of color were the victims. And then the second surge was statewide. And then the third surge almost, certainly proportionally was not as bad in Southeast Michigan, but I'm not sure there's a policy rationale for that.
I mean, I think some of it's an infectious disease, right? Like, it turns out if there's a kid in your, look, I live in Ann Arbor. Not all of our Ann Arbor folks are so good about using modern medical therapy for lice, right? So you get lice if there's a kid in your kid's class who has lice. And you don't get lice if there's nobody in your class. We saw this was an epidemic that, when it disseminated across the country, hit cities first. And there are lots of reasons, probably having to do with high density and having to do with where the airports are, right? And so the initial wave here, as everywhere else, was concentrated in major urban areas, because that's kind of, right, when you see the maps from every pandemic movie, that's where they come out from, because it travels on airplanes. I think the second and third surges, we'd gotten out to endemic transmission. And so everybody's classroom had a little lice. And while I agree that it's Detroit's epicenter-ness has been reduced, I don't think I've seen any data that convinces me that Detroit has been protective. I think it's just been less bad. I don't think it's been less exceptional. I don't think it's ever been less bad.
Sure, I agree about that. So we have 5 minutes left on our time slot, and let's talk about hey, maybe this is just, a really bad flu, and it's going to become more like the flu as we go along, and we can adopt this into our world as, as the flu. Do you want to comment on how viral pneumonia might not be quite like the flu? And I think that this fits really well in with Dr. Flanders' findings on how people surviving COVID, what happened to their savings and what happened to their jobs, and how this is perhaps not like the flu.
Absolutely, right. So we wanted this to be a quick viral pneumonia that's over and done, like one of the various childcare rots your kid brings home from school, right? Like, everybody in the house gets sick, and then everybody in the house is better next week. It's just not, right? That we're seeing maybe half of people have new prolonged disability that we need. And for them, the epidemic's not over, right? Scott showed very compellingly that for lots of people, the acute epidemic's not over. But even for those who have been through their acute illness, COVID's not done with them, however much we might want to be done with COVID. We know there's enduring disability. We know that 20% of people have a new oxygen requirement. We know that there are people who've lost jobs. And it's ridiculous to try to imagine that's just because we were a little more generous with our benefits. People can't work because they can't work. And we right now have no statewide infrastructure to provide ongoing care for post-COVID survivors and for the complications that are showing up and are ubiquitous. And we need to learn from that. Right? Nobody knows what 24-month follow-up from COVID looks like because there are no people who had COVID 24 months ago. We're going to need to build an infrastructure that walks with these patients, provides them care, make sure that we can prevent the COVID, we can fix as much of the COVID stuff as we can fix, but then also make sure that we don't misattribute good old-fashioned cardiovascular disease to COVID and miss other opportunities, because one of the challenges of being in a data-free zone like we are with post-COVID is that we could so easily misattribute other preventable illnesses to COVID, and then people are going to die of other things. And so we've got to find some kind of a structure that recognizes that a third, half, maybe 2/3 of these people, regardless of their initial severity of illness, are going to have ongoing consequences attributable to COVID, and that provides them care. And just because we'd like that not to be true, doesn't mean these people aren't sick, doesn't mean they're not losing jobs, doesn't mean their caregivers aren't taking time off from work. And a lot of these, Laura, and you and I have talked about this, right, are not 85-year-olds who have lots of other comorbidities, right? These are 40-year-olds who are never going to work again, who are losing 35 years of productive labor from, and whose children aren't going to get to see them work. And we're losing all those benefits if we don't find a way to have service. And we've done this before, right? Obviously, for the providers in the room, the state's really quite remarkable care for TBI after auto accidents is an example that you can provide longitudinal care. But when we discharge you after a heart attack, your heart attack's over, but we don't say, okay, we're done with you. You never need to think about your heart again. We discharge you after a stroke, your stroke's over, but we don't say, okay, we're done with you. You don't need any follow-up care. We've built post-acute care systems for people in both not just the inpatient set, but in the longitudinal care for years to help them deal with that. And I think we need to invent that for COVID. And that's going to take funding.
So we'll have to leave it there. I think we probably raised many topics for people to consider. And it looks like, I don't know if I'm handing it back to Elizabeth or Dr. Flanders or Jennifer.
Well, I believe, first of all, thank you, Laura, and thank you, Jack, for a terrific conversation. We do have a break scheduled right now, and we've recognized that going 2 hours straight without giving people a brief respite doesn't work as well. So 5-minute break. I've said this before, the restrooms are out the door and down the hall, wherever you may be. Please do what you have to do and come back within 5 minutes, and we'll kick it off with another panel discussion. So we're looking forward to having you all come on back. 5 minutes. All right. I do think we have completed that 5-minute break. So I think we're going to transition on to the next section of our presentation this morning. And I'm thrilled to introduce Dr. Rania Esteti. She is a pulmonary critical care physician at Covenant Healthcare in Saginaw. She's an assistant professor at CMU and also president of our Society of Critical Care Medicine Michigan chapter. She's going to lead a discussion focused on adult and pediatric critical care. So Rania, I'll turn it over to you.
Thank you so much, Dr. Flanders. Thank you so much for the opportunity to be here today. I think we are all very excited to be able to share our experiences as well as our thoughts on everything that we handled over the past year. I'd like to warmly thank all of the panelists that we have today. And I really do appreciate you coming together in order to discuss your experiences as well as your institution's experiences as far as how you dealt with COVID-19. And I think it'll be really nice to kind of go through the adult as well as the pediatric side in order to best understand how it affected us all. So from the adult side, I would like to formally welcome Dr. Max Tomei Kakasa. And he is an assistant professor of medicine and a program director of pulmonary critical care medicine at Spectrum Health in Grand Rapids, as well as his colleague, Dr. Rael Beljawi, who is also at Spectrum Health in Grand Rapids and with a special interest in cardiothoracic ICU and pulmonary embolism response team. On the pediatric side, I'd like to welcome Dr. Rodney Daniels, who's an assistant professor of pediatric critical care medicine, as well as an associate director of the Michigan Center for Integrative Research in Critical Care at Ann Arbor at the C.S. Mott Children's Hospital, as well as Dr. Nicole Sinclair, who's a pediatric intensivist and the pediatric section chief at Covenant Healthcare in Saginaw. Welcome all, and thank you so much for joining us today. Next slide, please. So I know that, Dr. Heise really nicely gave us a bunch of the kind of top 5 lessons that we learned over the COVID-19 pandemic. One thing that was also nice to kind of, keep in mind is how did surge capacity affect your particular institution? I know that there are different institutions that are larger hospitals versus some of the hospitals that are more in the community. But I'd like to kind of touch upon each one of yours experience as far as how you guys dealt with surge capacity, whether it was in the form of triage, in the form of ICU resources, or shortages of equipment. I'd like to start off with Max, if that's okay.
Well, thank you, Rania, and organizers for the invitation. It's a pleasure to be here today to share our experience. So regarding the question, I think that as all the institutions, we were affected by the surge and our capacity, and the way we triage has been dynamic since we started the pandemic. As we learn more about it, we provide care to all the critical patients, and the distribution of the COVID patients has been limited to certain areas. But as our experience increased, we practically we were able to allocate all COVIDs in all the ICUs, depending on the complexity of their case. But for what was important was to increase the capability to take care of these patients and overflow ICU patients to medical floors with this, providing the same capabilities. So that requires not only beds, but also providers, nurses, and equipment. We had to increase the number of providers taking care of ICU patients. Also, nurses from the floors working together with ICU nurses. And in regional hospitals, their staff responded very effectively, taking care of ICU patients, complementing with our virtual ICU support. So it was a lot of work and a lot of logistics, but for the most part, as we continue learning and people got more comfortable with this new stage, I think that we were able to take care of all the patients. I don't know, Weil, if you have anything else
Yes.
to add.
Can you guys hear me?
Yes.
Okay, very good. So I just want to expand a little bit on what Max said. Clearly we had the advantage of not being affected in West Michigan as early as the other side of the state or other parts of the country. So there was sometimes for some contingency planning early spring, and that involved two levels. At the system level there, clearly a command center was established that involved both administrator leaders, nursing leaders, physician leaders with input from our team. We looked at what places would be used as overflow, including establishing some field hospitals in Grand Rapids if there was a capacity overflow. And that also coincided with closing of the outpatient clinics. So we were able to recruit these patients. The system did actually a pretty good job emptying the hospital early spring of last year in anticipation. So while the first wave wasn't too bad, when the fall wave came, we had to increase our medical ICU teams from 3 to 10. And because of this early planning, we were able to do that effectively. And I will add one more thing that I thought was also very helpful is the implementation of virtual ICU. So we have, as many big institutions, we serve several smaller rural areas in the counties surrounding Grand Rapids. And typically pre-pandemic, they will just send their sick patients to us. And this was not an option with the bed shortage. So just, being able to have the resources to implement the virtual ICU with 24-hour nursing and physician capabilities helped reduce the impact of the big surges in. But one lesson, you need early planning, and you can't skim on resources. Unfortunately, you just can't do it on the cheap.
Thank you. I'm curious to see from the pediatric ICU standpoint, as far as how you felt surge capacity affected your particular department. So I'll start off with Dr. Daniels. Although you may have not seen the same amount of numbers that we did in the adult ICU, how did you and your department, how did you get affected with regards to the surge capacity when this all started?
Thanks for that. Yeah, it's really interesting because we didn't really see a surge per se in pediatric patients so much in the beginning. Detroit got hit, a bit harder, but at the same time, our surge affected us uniquely in the fact that we were pulled to treat adult ICU patients. So half of the faculty in pediatric critical care medicine here at University of Michigan actually manned a smaller version of what we call the RICU here, which is the COVID ICU, one of the COVID ICU units here at Michigan. And, affectionately, we called it the Little Ricky because it was a little smaller than the RICU, and also was a playoff on the ped side because we were all pediatric ICU providers. We felt some of us, I was med peds trained, not all of us were though. So that definitely was very unique. So half of us was covering the regular peds ICU, which actually had a decrease in patients overall, just because we didn't see as much bronchiolitis. We didn't see as much of those things with all the isolation that was going on, which was a semi-positive of what happened. But we were manning the adult ICU. So that was unique. We had providers and consultants from adult ID, adult room, et cetera, as we needed them. So we didn't use pediatric consultants for that. But we were using all pediatric ICU providers for that unit. It actually, I think, went overall relatively well. We all just pulled together and made it happen. So the surge, affected us more in that way and putting us into a unique position that, was unique to this pandemic. We spent about a little over a month there. Some of my colleagues, Dr. Carlton and others, had really tried to put up that unit early and get it ready to go in case we needed it. And they did a great job doing that. We manned it for, again, about a 6 weeks time period total. And most of us were there for about a month doing that. So that was very unique in that way.
Dr. Sinclair, did you see any changes that affected you, whether it was in the first or even in the subsequent waves as far as surge capacity within the pediatric ICU?
So pediatric care, it's pretty seasonal. Generally, December and January are our busiest months. But like what Dr. Daniels was saying, we essentially did not have an RSV season. So we had a lot of empty beds. Whereas you guys were full almost the entire time. So we did open up a couple beds for non-COVID adult patients to come down to the Peds ICU. But unlike at Michigan, adult intensivists still took care of the patients. A lot of our nurses were sent to the adult ICU floors, knowing that we had a lot of open beds without having RSV and other viral infections. But that was basically what we saw at Covenant.
It was definitely challenging to find out where the PICU was. I remember having to go see adult patients down there. And so definitely it was an experience in kind of learning where everything was in the PICU.
Well, I hope it was a positive experience.
Oh, definitely was. So Jennifer, we'll move on to the next discussion point. And I'll actually like to start off with pediatric ICU with this question. So Dr. Sinclair, with regards to the type of patients that you saw, how would you explain the difference between kind of the demographics with regards to ages that we saw between the first and third wave? I know that initially we saw a lot of adults, older adults, sicker adults, ones with more comorbidities. But as the wave progressed, we tended to see a little bit more of the younger population. And maybe you and Dr. Daniel started to see some of these patients pop up in your ICU. Do you have any kind of ideas and kind of why or how this happened, or anything to kind of explain this difference in demographics?
So our demographics pretty much mirrored that as well. During the first and second wave, it was mostly older teenage patients. Obesity was a major risk factor, as I'm sure is similar in the adult population. History of lung disease, asthma was something that we saw. So definitely an older population with more comorbidities in the first and second wave. The third wave is interesting. I would say it was during the third wave where we had most of our patients. And most of what we saw was the syndrome known as multi-system inflammatory syndrome. And so in 1 week in our small community hospital, we had 3 cases of MISC. So this is kind of what we were seeing, and it was as expected. During the first wave and the second wave, children are relatively protected. They weren't in school, they weren't doing sports, and then they all went back to school, presumably had a COVID infection, either asymptomatic or symptomatic, and then 4 to 6 weeks later, developed this antibody response. So that was what we mostly saw during the third wave. Again, there was still some older teenage patients with obesity, but mainly we were generally spared, except for I will say these MISC patients were 3 of the sickest patients I've probably taken care of in the last 3 or 4 years. So it was interesting, and I think there's still a lot to learn about long haulers and pediatric patients, as well as whether the neutralizing antibodies, now that it's opened up for this age group, if this is beneficial or if it would increase the risk for MISC.
Dr. Daniels? Any other?
Yeah, it's interesting. Our first wave, we also saw relatively small numbers of pediatric patients, really small, because we do tend to see a lot of more complex patients. We're kind of a quaternary care center here. We did see some patients with complications that had some underlying medical issues that had COVID. But again, it's interesting because the first wave, it did seem to be a bit more of systemic effects that we saw then. Didn't really see much respiratory. I mean, we saw some respiratory, issues, but it wasn't the respiratory failure like you were seeing commonly across all the adults. And then the third wave, we definitely saw this past spring a large increase, relatively speaking. Again, very, very small compared to the adults, but a much higher increase in pediatric patients coming into the ICU, a little older, as Dr. Sinclair had mentioned. They tended to be, we do see some teenagers, and those were 19, 20, et cetera. And we did see more respiratory failure, just anecdotally in the spring, at least here at our center. We still would see MISC, we had to look out for it and look out for systemic effects, but we were seeing a bit more respiratory failure in the spring. So peds, relatively small numbers overall, certainly compared to adults, but a little difference in how the variant in the spring, British variant, et cetera, was affecting our peds patients versus the first variants in a year ago in the first wave.
And while Dr. Berjawi and Max, anything in addition that you would like to add as far as the types of patients that you saw initially and then more subsequently, and kind of the difference between why we saw older, sicker patients get affected more with comorbidities versus a little bit later down the line when we saw a little bit more of the younger population with less comorbidities?
Yeah, I can start with answering that question. So clearly, during the three different waves, we saw three different distinct patterns. The first wave, as you said, affected mostly nursing home patients, elderly patients, as there wasn't as many restrictions to nursing home visitations. And we definitely saw a more urban predominance of patients. And what was interesting is we saw a higher, similar to other places, but we saw a higher number of minorities, especially Hispanic men, get affected. And to understand West Michigan, Kent County is about 75% white, 15% African American, with a growing Hispanic population. And we felt that the same risk factors, those social determinants of health, multi-generational homes, not being able to work from home, and frontline workers. What's interesting in our fall or second wave, we saw almost an equalization between our rural and urban population. And one theory is, as most people could not leave Michigan because of all the restrictions, everybody flocked to the northern part of Michigan, to the UP, and a lot of interactions. And of course, we saw less nursing home patients, and we tracked our data by race very closely. And what we found, it's interesting, by the fall, we basically had equalization of percent of population in the community to what we were seeing in the ICU. And then with the third wave it clearly became a question of the vaccine. More urban areas got vaccinated, as the numbers shown. So we're seeing definitely more rural patients now where there's more vaccine hesitancy. So it was interesting to see this epidemiological change over the last 14 to 16 months, reflect everything from public policy to people's behavior to risk mitigation.
I always feel like it was like a social experiment to kind of see how this pandemic played throughout all those hoops. So it was definitely interesting and challenging to see how these patients reacted to a lot of our management. I'm going to go on to the next question, Jennifer. And what I really want to know, and I think Sir William Osler really put it nicely when he said that you will draw from your errors the very lessons which may enable you to avoid their repetition. And so knowing what we know now, how would that have changed your approach in managing these patients? And this question is mainly more along the lines on, if a fifth wave were to appear, how would you expect it to be different? And would you approach it differently knowing what we know right now? And I'll leave the floor open who would like to chime in first.
Well, I think that what we know more now is that the sooner we are able to intervene or prevent is the better we are able to reduce the surge. During this third wave, talking to our ID colleagues, I found out that how many patients were receiving treatment with monoclonal antibodies with high risk factors. They were early in their disease, and extrapolating the risk of having a progression to a severe disease, I think that really helped us to have this surge even worse. So we were really flooded with patients, but I think it could have been worse if many of these patients who did not receive treatment would have progressed to severe disease. So I think that the more we prevent this progression to severe disease, the better. And now that we have the vaccine, we should try to educate our communities about the importance of vaccination. Second is that before COVID, I think that we knew about management of ARDS, but sometimes it was hard to implement, how quickly we would start paralytics, prone position, and as we learn about COVID and we saw that many of them end up with ARDS, we improve the logistics and coordinations between ICU members, team like nurses, respiratory therapists to implement prone position when appropriate. And regarding a specific treatment, I think that now it's clear steroids and tocilizumab in certain population is very useful. During the first wave, we started using tocilizumab. And I remember that we had good outcomes. By the time of the second wave, we stopped using it because all the evidence was ambiguous. And I think that now that we have more evidence with rep cap and recovery, we started using it again. So I think that the way we would say is that better coordination ICU in management of this patient and try to prevent progression to severe disease.
Thank you. Jennifer, with that, I'd actually like to piggyback onto what Max said into the fourth question, which was actually one of the questions I think a lot of us really struggled with, is decision-making in a pandemic. So how do you balance anecdotal evidence with rapidly emerging data? We know that this COVID-19 pandemic has resulted in unprecedented research worldwide. And this has been paralleled by an explosion of the biomedical literature relating to SARS-CoV-19 with, I think, maybe even more than 64,000 papers at the time of this writing that came up on this topic. And I know that initially we started off with nothing, a few anecdotal evidences, some small papers, some expert opinions. How does the frontline worker or provider do the right thing as it relates to managing a sick patient in the middle of a pandemic? How do you manage this challenge to surf the COVID literature tsunami? I know it was a challenge for a lot of us. I'd like to touch upon, maybe see what Dr. Borjawi has to say as far as how you guys manage to try to develop protocols and try to, manage the different types of managements that came out in the midst of this pandemic.
Okay, am I taking this question first?
Sure.
So, I just, before I answer it specifically, I was really, when I was listening to Dr. Heisey and lesson number 4, that this is, at the end of the day, this is ARDS. And if there's one thing we know as critical care physicians is, hopefully how to manage ARDS. And initially there was a lot of hype that this is something we've never seen before. And there was this search for a panacea. I remember from the H1N1 epidemic, that voice of the high frequency oscillator, many of you, remember those days. And of course, we don't use that now. So I do think, it is very important to understand what we're treating, and this magic drug does not exist and will not exist for viral induced ARDS. So if we start there, what we've done at Spectrum, early on, there was a task force that was tasked with basically reviewing the literature that was made up from our clinical pharmacists, immunology and allergy colleagues who took the lead on prescribing tocilizumab and anakinra, our ID colleagues. And then we just had we had to have the modesty of changing course as new evidence emerged. And we would say, tocilizumab for everybody is not the answer. Of course, Plaquenil, we will not go into that. Fortunately, we never had to prescribe ivermectin. But I think, at some point, just having that urge to always do something can be counterproductive. And I do feel that sticking to what you know best as an ICU physician and waiting for consensus to emerge, not to mention, obviously, picking up the phone and talking with our colleagues at the other side of the state and saying, what are you guys doing with anticoagulation? What's your experience been with that? That has been helpful. So that's what we've done at Spectrum.
From the pediatric side, any last longing words that you guys experienced as far as how this challenge affected your decision making?
I'll jump in here because I think this has been a unique issue on the PED side because there's a lot less data. The data comes from Europe as well as the United States. There can be differences in what's going on because, regarding variants and everything else. And, the rheumatology groups across the country have kind of come up with a lot of the guidelines from the inflammatory state side, the cytokine side. So we do have some guidelines we go by, but, some of the things we've heard of, it is, you want to think about, well, this anecdotal evidence and how much is real, how much is going to be helpful. It's hard though, because you don't want to just jump onto something that may or may not be beneficial. So, but there are guidelines, by the way, interestingly enough, in PEDS that we do start with IVIG for like MIS-C disease, so systemic inflammatory disease in children's. We'll start with IVIG and then glucocorticoids. If it doesn't seem to be working, then we'll move on to potentially doing anakinra. It's actually become more the favored drug for the PED side, IL-1 blocker. And we use that quite a bit actually it seems to be helpful in those severe cases. I will mention that on PED side, we have a lot of Kawasaki-like illness in PEDS. It is not the same etiology though, because there's actually in true MIS-C disease, there seems to be more of a heart failure portion of patients with MIS-C versus Kawasaki with less aneurysm type evidence versus Kawasaki's as well. So even though they're similar, there are differences and they're unique. And so echoes and things like that are important to do in the MIS-C kids. And so we do watch the cardiac side of things. And that is, one of the major factors for us to continue to ramp up therapy as well if we see any type of cardiac dysfunction. And so we watch them over time. But coming back to it, it really has been interesting and a little difficult because the information on the PED side has been so sporadic. So that's been a problem. And I just wanted to put out there also, I wanted to make sure I mentioned Dr. Kristen Smith, who really put up the Ricky side for the PEDS people going there. She did a great job, our faculty, and Laura Baker, who was one of our nurses. I didn't mention them before. I have to mention them because they're PEDS people that really stepped up and tried to help with the unit again in a sporadic evidence. So.
Thanks, Dr. Daniels. Jennifer, we'll go to the next question. And in the interest of time, I just wanted to put it out there as far as kind of what everybody felt as far as the remaining questions would be. And, I guess one of the things that I particularly still wonder and is kind of what are the long-term effects? What are the long-term complications of patients with ARDS secondary to COVID-19 as far as their lung function and what kind of future can any of this be managed or prevented? I would actually really interested to see some of the data coming out of some of the post-COVID clinics that they have out in the country, as it'll be interesting to kind of see how these patients manage the late complications and how they can be managed or prevented. So I think hopefully we'll get more data from these post-COVID clinics to see how these patients are 24 months down the line. And with that, I wanted to thank all of my panelists for truly giving me the time and their expertise today in giving us a sense as far as how this affected the adult as well as the pediatric ICU population. And we are truly appreciative for your time and your expertise. So thanks again for joining us today.
Thank you.
Just a quick word. I know we're in the interest of time. I just wanted to quickly give you a little snippet about Society of Critical Care Medicine, the Michigan chapter. And this really was born during COVID. Once the pandemic hit, me, a trauma surgeon and a pharmacist, all from different areas of Michigan came together and said, you know what, how are we doing things? How can we collaborate better? How can we provide a platform for all these people to come together to talk about critical care in general, but definitely to try to bring people together with the midst of the pandemic. And that's how kind of the Michigan chapter was reinstated. Currently, we have 126 members. So it was born in September of last year. We developed our board of directors in January and our committees in February, and we were able to have a webinar in March, and we just recently completed a research symposium in May. So we've been very busy, and we've tried to ramp it up as much as possible, and really would love to invite everybody to be a member in order to enhance this and foster this collaboration that all of us are here in today. Next slide. This just shows you, how variable and diverse we are. I'm pulmonary critical care, and our president-elect is a trauma surgeon, and our secretary-treasurer is a pharmacist, a PharmD. And you can see that our board of directors range from all regions in Michigan, from central mid-Michigan to northern, southeastern, western. And we really wanted to make sure that every single part of Michigan gets represented. So I just left it over here for you guys to join. Our website is pretty easy. It's sccmmichigan.com. We're also on Twitter, so SCCM Michigan Chapter, and we also have an email, sccmmichiganchapter@gmail.com. We do have a virtual conference coming up in September, and would love it if you guys could all join. So with that, I'll hand it over to, I believe, Dr. Flanders or Jennifer.
Great. Thank you very much, Rania. And let me also extend my thanks to all your panelists for really a terrific discussions and for all the engagement over the pandemic so far, and really a valuable session. So next steps. You can go to the next slide, Jennifer. So just to update you on the registry, we are no longer adding COVID-specific cases to the register. However, I alluded to this previously. The Michigan Hospital Medicine Safety Consortium had just launched a sepsis initiative, started to at the outset of the pandemic. And we have continued to refine our approach to that, our data collection strategy with respect to sepsis, and now have over 10 hospitals in Michigan pilot testing our data abstraction strategy for the care of patients with sepsis here in Michigan. I can tell you right now, looking at our preliminary data, that nearly half of those patients actually are COVID-19 patients. So we will continue to have the ability to learn about this disease, especially those patients who are suffering sepsis, the most serious, one of the most serious ramifications of this condition moving forward. We hope to continue to engage the Michigan Society of Critical Care Medicine organization, intensivists, emergency medicine providers, hospitalists, infectious disease providers, our nursing colleagues, and others as we move forward with learning about sepsis and the COVID subset of that sepsis group. I do want to end with a huge thank you. This webinar, all of the data that was collected, that we were able to evaluate, share, really took legions of individuals, abstractors, physicians, quality leads, frontline staff at numerous hospitals. Many of the Blue Cross Blue Shield of Michigan CQIs really threw their weight behind the effort of managing COVID. And I hope what you saw today was a prime example of providers, teams coming together across the state, breaking down barriers that may exist, whether it's for systemness, financial barriers, different markets in the state. Everybody really set those aside and came together in the interest of caring for patients with this condition across our state. And I am blown away by what the group has accomplished. So really applause for everybody. Thank you, everybody. We are well positioned, I think. God forbid we have yet another surge or keep managing this disease. But I will say we are prepared. We have the ability to continue to learn and share moving forward. So with that, I think we'll conclude our webinar. Thank you very much for your attendance. We will post slides and a recording of this to our website, as we often do after all of these webinars, if you'd like to share it with others moving forward. So thank you for your attention. Have a great day and be safe.